Things first, at the end of the discussion last month, and we were talking about strokes, I had a question asked to me, and the question, whatever I said that there was no pain when you had a bleed. That's not true, okay? The way that all works is that if you have a bleed in your brain, there's no room in the brain to expand. So that's where the pain comes from. You know, in the ischemic strokes, I don't see pain. So that was my error. I wanted to make sure I corrected that. Now, what's today's topic? Okay, now I won't make anybody give me a show of hands, but colonoscopies, I'll call it a C-scope. Recommendations, if there's family history, 40 years old. No family history, 50-year-old. And then once you get those tests done, the doctor that did them tells you what's going to happen. So if everything was normal when you were 40 or 50, depending upon the family history, they may not have you come back for 10 years. Okay, but if they found something or if there's a family history, they're going to have you come back sooner. All right, the reason I bring that up is this is a month of colon cancer awareness. And again, the reason I bring up different topics is because of what I'm seeing in my practice. 2 males under 50, 1 rectal cancer, 1 colon cancer, and it recurred. So all the conventional treatment, and it recurred. When I see something like that, because usually I didn't see that age that often, okay? But why I bring it up is because it's colon awareness month, I'll put aware. Please, look at that, that's capital. Pay attention to symptoms. What does that mean? Remember we talked last month about stroke, and you know if your finger's numb or something's not feeling right, you know your body better than anybody, okay? Same thing goes for the colon. You know, what's so important are your bowel habits. So if there's a change in your bowel habits, a lot of patients like to say, oh, well that was, I drank X, Y, and Z. Or I was over Aunt Mary's house and I ate cabbage. You know, that's okay to think that, but you also know, are you fooling yourself? And generally what I tell patients is 3 weeks. Now, if you go travel someplace or you've been someplace and your diet has changed and the bowels have changed, what you need to make sure you do is after 3 weeks, if they still haven't improved, you go see your doctor. Because once again, guys, this is colon cancer awareness, and I'm going to run through everything. You'll understand it at the end, but what I want to make sure of is we highlight the points. When I start seeing younger males getting colon cancer and it's not treated and cured, that's a concern. And so what I look at is, what's the difference? And we'll talk about that. There's so many people drinking these high energy drinks. Okay, remember the commercial? I think it was a butter commercial where it said you can't fool Mother Nature. You can't fool your body. So whatever you are taking in, if you yourself are not reading the ingredients, you're doing yourself a disservice, and you got to make sure you're paying attention to what's in there, because some of the things that are in there are being looked at as risk factors. And once again, I looked at why was I getting young people. Both of these guys, bodybuilders, taking supplements to put on the muscle. Both denied steroids, but they called it workout. That was the name of the product. And it had things in there that made them get like a rage sometimes, make them get upset. And it had a ton of caffeine, a whole bunch of caffeine. Okay, so again, that's the awareness piece that I wanted to make sure everybody knew about. And when I say pay attention to symptoms, you know your body. So I say, know your body. And if there's a change, you can give it 3 weeks. Well, what does that mean? I had a patient tell me that there was blood in the stool only after her husband made her. And then what she said is she hadn't eaten beets in forever, and she started eating beets again, and that's what it was coming from. But the point was, she knew there was a change. And again, the sooner you catch any kind of cancer, the better chance you have for curing it. All right, so everybody with me? All right, so what we want to do, since it's colon cancer, we want to understand the colon. So this is the esophagus. We're doing just GI. Esophagus, stomach, and then we'll put over here the liver, and underneath the liver is the gallbladder. And this C-shaped piece is called the duodenum. So the gallbladder secretes. Back here is the pancreas. It secretes. And then we have 150 feet of intestine. Remember, we used to say, you go over to George, probably and back. And the way the intestine, the small intestine, it's fan-like. So it's all pushed together, and the function of it is to start the metabolic process. Over by the right side at the cecum and the appendix, and I'll put dots, starts the colon. Okay? Appendix. Right here. This is the right side, or what we call ascending colon. This is the transverse colon. This is the descending colon. S-shape for sigmoid. And then, of course, the rectum. And what happens? When you eat your food and it makes its way down, there is a process of digestion that occurs every time you eat something. And so the enzymes that are produced to break down the food send it to the small intestine and then ultimately to the large intestine to be evacuated. The process is very simple to understand. What does the colon do? 2 things. Contracts and absorbs water. That's all it does. It just contracts and absorbs water. So what does that mean? That means if you don't drink enough water, and how much is enough water? 12 10-ounce glasses a day. Now, I'm not your doctor, so check with your doctor, because if you have liver disease, heart disease, other diseases, 10, 12 might be too much, but make sure you get the water that you need in. Because if you don't, your colon is going to absorb through the stool that's making its way through to get the water that your body needs. And ultimately what happens, that can lead to bowel habit changes. Or it can lead to discomfort that can ultimately lead to different processes in the colon. So that's what we want to make sure everybody understands. I'm going to blow up the colon now just so you see, but we'll come back to it. So basically, there's the appendix. That's the ascending, transverse, descending, sigmoid, out to the rectum. Okay? And what occurs now is, let's talk about the test since we just drew it. The C-scope, what happens? They put you to sleep and they pass the scope all the way over to the cecum. And what they're looking for is the lining of the colon, because that tells them the story, that tells them what's going on. And if the lining of the colon has no polyps, has no diverticuli, and we'll go over all that, it has good, smooth, pink mucosa, there's nothing wrong. And of course, that's what it's supposed to be. The problem, diet. Do we get enough fiber? No. Our fiber is low, and we'll talk about that in a minute. And what else is high? All right? So remember, what does the colon do? Contracts, it absorbs water. And based on your constitution, some people go 3 times a day. Some people go 3 times a month. Everybody's different, but that's who you are. That's how your body works. Whatever your constitution allows, from the small intestine, we'll just put SI, small intestine, okay? The food makes its way around. When it gets here, it's liquid. And of course, when you move, you don't want it to be completely rock solid, but it's more solid. And that whole process is your constitution. It's who you are, how you are, what you do, how you do it. And if you find yourself, that's what we call your normal bowel regimen or routine. So if you find whatever yours is, that it's changed in any way, let your doctor know. And a lot of patients will tell me, well, he or she didn't ask me. And that's unfortunate, but you have to make sure that the bowel habits haven't changed, and make sure that the consistency of the stool, etc. Don't blame on what you ate. Pay attention. Now again, if it's a one-time, because you really did have Aunt Mary's cabbage or something, that's all fine. You don't have to go running to your doctor all the time, but please make sure that you understand this is all that the colon does. Contract and absorb water. What's fiber mean? Fiber is not absorbed where? That's your lesson today. What did we say? The colon only contracts and absorbs water. So the small intestine. So what happens is, if the fiber you eat goes through the small intestine doesn't do anything but send it to the colon. So what occurs is, there's more things in the colon, all right? You have to understand this. This concept will help us a lot. Garden hose. Okay? Temperature, volume, pressure. Temperature doesn't change, right? Colon, contracted. Marble on this side, trying to get to this side. How's it going to get there? If you don't have fiber, pressure has to occur. What does that mean? The colon contracts. What does that mean? Increased pressure. What does that mean? Bloating and gas. What does it also mean? If you don't have enough fiber over the years, you're going to get diverticuli. What are diverticuli? Think of the green garden hoses. Remember? My mother used to put them out for us to get out there for the sprinkler. You lay it down and it had holes in it. Think of that as a diverticuli. What happens is the pressure inside the colon gets so great that the muscle bulges out. So what do you see? Inside you see a hole, and outside you see a pouch. So when the doctor looks inside there with your colonoscopy, he sees many of these areas of diverticulosis, and it comes from not enough fiber. Remember, that's the only way it gets across. Temperature doesn't change, pressure. What's volume? Fiber. And fruits are good if you eat the skin. I found that out. If I don't ask my patients if they eat the skin, they say, I eat 4 apples a day. And then you bring the husband in. Yeah, but I have to peel it for her. And I was like, that's not quite what we're talking about. You have to have the skin. Okay, that's the best fibrous part. I don't necessarily recommend, the pills and the powders, and yet, if you're not getting in enough of fiber on your meals, then definitely, I can't think of the right name right now, the one that's the most common. But there's different ones out there. You just put a spoonful in a drink, stir it up, and that's plenty of fiber. There's fiber pills, FiberCon is one of them. You got to get the fiber in, guys, please. But understand this concept. Temperature doesn't change. The volume is the fiber that the small intestine does not absorb. And remember what we talked about. Whenever the food makes its way down to the cecum, okay, once it gets here, it's still liquid. So you put the fiber in, You have plenty of liquid, so now there's liquid and fiber in the colon making its way around. And because you have the fiber, every time there's a contraction, everything moves. Does everybody follow the concept? Please understand that, guys, because that's what you want to get to. You want to get to the point that every time the colon contracts, there's movement, okay? So increase the fiber, you'll see that. And again, will it hurt you if you don't have the fiber? No, but it's considered a risk factor. High fiber and low fat, no risk. Low fiber, high fat is a risk for colon cancer. Because the low fiber, you need more pressure. The stool sits there longer. You know, the only thing that's happening is water's getting absorbed, but there's thoughts that those are the things that cause the mutation that leads to the polyp, and we'll talk about that. Then the polyp forms the cancer. Does everybody understand the concept? All right, so now let's get to some data that's striking to me. 1 million cases in 2022. Oh, this is global. Everything's global now, guys. And of the 1 million, there were 680, no, that's not right. I don't want to say it that way. These people didn't die. There were 680,000 deaths from colon cancer in 22. I don't want to make it sound like the million that got it, 680,000 died. I'm just trying to show you statistics, the incidence, you know, and how many people we see. 680,000 people died of colon cancer. And all the stuff I'm telling you, these are the things that today's the awareness. Everybody has to understand their GI system. Everybody has to understand how it works. Everybody has to understand your own constitution. And if you see a change, just bring it up to the doctor. Once again, I'm not telling you to go run to the doctor immediately, but at the same time, you bring it up. Because bringing it up, things change. All right, so that's the statistic that caught my attention. Risk factor. Number 1, colon disease. It's tops on the list. One of them is called ulcerative colitis. One is called Crohn's. Now, does that mean if you have this, you're going to get colon cancer? Of course not. It's a risk factor. All right? Other things are inflammatory bowel diseases, not of this, but let's say related to a type of arthritis or lupus. Okay? So there's inflammatory bowel diseases that are out there. Other risk factors, sugar. And that's why I do believe, remember the young guys I told you I'm seeing? You know, they were bodybuilders and drinking all this crazy stuff. There's a lot of sugar in those high energy drinks. And people aren't paying attention to it. They just get that high energy and they love it. But once again, that's a big risk factor. What else is sugar? Alcohol. And remember I told you, the doc I trained with, as long as you don't drink more than I do, you're fine. Okay? But again, pay attention to that because it's there, guys. Smoking. All right? And I have to list medications. Okay? What's interesting is my mother had colon cancer. And she had stage 4, I think she had something like 8% is what the textbook said of living. And she lived 30 years. But the treatment that she went through to live the 30 years affected her bone marrow. Does everybody understand me? Now, what are you going to do? Trade off, 30 years and then a problem with the bone marrow 30 years later? Of course not. But the whole point is that all medications have side effects. And I hope you guys are listening to some of these crazy commercials that are on TV. They tell you, oh, it's wonderful, da, 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 da. And then someone gets in real fast at the end and says, and there's a risk of sudden death. And it's just crazy the things that they'll tell you. So please pay attention to the technology is phenomenal. And we're going to go over some of the treatments now that are out there. But pay attention to what you're taking. Pay attention to what you're eating. And we'll go over all of it. These are the ones that I want to make sure everybody understands. Does that mean don't take your medicines? Of course not. Talk to your doctor if there's a risk of any type of cancer with the medication you're taking. Smoking, I hope people see the obviousness in the smoking. It's a couple hundred degrees in your mouth. So that in and of itself, your body's immune system is activated. What does that mean? There's inflammatory cells circulating through your body. What do we know? Inflammatory cells cause trouble. They're excellent to cure a problem, but if you continue to smoke, it's a chronic situation to your body. And that 200 degrees is not a good thing for any part of your body, but specifically the colon. If when we go through what we're going to go through, if you're not reading labels and paying attention, we're putting things in that irritate and can mutate within the colon, and that's what's leading to the problems we're seeing. So everybody understands that. Alcohol, I don't know how to, I go based on what I see, and from what I see, if a person has a problem related to their alcohol that their body's telling them, what does that mean? Your liver functions are up, or you have problems related to alcohol consumption, then that's a whole different story. But in general, I think that alcohol is something that's controllable, but it is also a chemical, and that chemical can have adverse effects. What I warn you about more is because what's above it? Sugar. Alcohol is sugar, guys. That's what it is. So if you're taking in sugar, also drinking alcohol, eating your desserts all the time, pay attention, that's a risk factor. So we gotta be aware of what we're taking in. Alcohol is sugar. And I didn't realize, what's the other one? Vinegar, ammonia, all the stuff we get out of like sugar is incredible. I didn't realize that. Did you guys know that? You know, it's a byproduct. All right, the inflammatory part we talked about, the ulcerative colitis we talked about. Other things that you want to make sure of with the colon, I'll put the risk factors we talked about, family history we talked about, and we'll put bowel habits. If you pay attention to this and follow what we're going to run through now in terms of nutrition, I don't think you have anything to worry about at all. But minimum, the Cologuard they call it, you know, docs like us get them in our office that we can get the patients. So please make sure, at a minimum, you do the Cologuard every year. And if you've had any GI problems, your GI doc's still seeing you. And if you have a change in your bowel habits, or I'll even put eating habits. What does that mean? If something's going on downstream, the pressure builds up, you can lose your appetite, taste can go away, different things can happen. So you want to make sure eating habits go into bowel habits, they're together. If you see a change, especially I tell patients, if you generally ate a plate of food and now you can only put in a quarter of the food and something didn't just happen. Now it's different if you were in the hospital for a while or you had other medical problems, you wait till you're back to yourself. But I'm just saying in general, if you feel wonderful, well, yourself, and all of a sudden you're seeing changes in the bowel habits or the eating habits that you're getting filled up quicker than you normally did, or you lost the taste for something that you used to like, those are changes. Those are things that you have to talk to your doctor about. There may be nothing to worry about once they go through everything, or it may be something you want to check with the GI doc. And if you have the GI doc, you tell them as well. But please, these are so important. The risk factors we talked about, family history, and definitely these habits are important. I better put drinking too for, I said eating only, we'll put drinking in there too. If you're taking in a lot of sugar, carbonation isn't good, all those things are risk factors. All right, now, what happens? A patient comes in to see the doctor. MD visit. What's the number one thing? Patients come into the doctor that we find, patient visit, and we find colon cancer. GI bleed. What does that mean? That means that whether you're finished your bowel movement and when you wipe yourself you notice blood, or you finished your bowel movement and you're flushing the toilet and you see blood, or you see blood in the stool. If there's blood, that's not normal. And once again, if you have hemorrhoids and you know they're bleeding, that's fine. If you know that you strained and you normally don't, that's fine. You can call the shots yourself. But what I tell you, 3 weeks. You know, why is that 3-week window? Well, it's not going to grow fast enough to cause you, a prognosis to changes. But the 3 weeks is the time period that if it is something strange, it should, cure itself, if you will, in that period of time. But I emphasize it's the most common thing we see for colon cancer. So GI bleed is nothing to just forget about. Sorry, that's my bookie guy. Did you guys see the All-Star game? Schemes, the pitcher for the Pirates? First time in a lot of years. But that really wasn't my bookie. All right, so that's number one. GI bleed. What's number two? It goes along with it. Anemia. This is a hard one for patients to understand. Anemia comes in many flavors. And what does that mean? We characterize it into what's called microcytic and macrocytic. What does that mean? Micro, small, macro is large. So there's large cell anemias, small cell anemias. GI bleed goes into microcytic. But you can have problems with anemia such as B12 deficiency or folic acid deficiency, where you'll be anemic and the cell will be large. So my reason for bringing that up is there's some people, possibly even sitting in this room, that their normal hemoglobin could be 8 to 9. But it's totally normal for them based on their history. Other people, if they're at 10, they're severely anemic and may even need blood depending upon what variety of anemia they have. One of the most common that I see in my practice is what's called chronic anemia from chronic disease. What does that mean? That means if you have a disorder, say ulcerative colitis, let's say rheumatoid arthritis, lupus, let's say chronic, what's that one where Lyme's disease, different things that your body's fighting off every day because it's a chronic problem. The blood turns over faster and you will have an anemia, but that needs to be proven. It's kind of like irritable bowel. Everybody's heard it. We're going to talk about it in a minute. Irritable bowel is a diagnosis of exclusion. You have to see the doctor. They have to do a colonoscopy, make sure everything's normal. Then they will put you in that category of irritable bowel. Just like systemic lupus erythematosus. There's 25 characteristics. You have to have 11 of them to make the diagnosis. Does everybody follow me? So I put up anemia here and circle it because that is individualized. There's not a number that you look at and say, oh, I'm at 12 hemoglobin, I have anemia, I might have colon cancer. It's up to you and your doctor to talk to he or she about it, okay? But that's another, when they come into our office. Another big one, weight loss. You know your body, you know how you are, especially now with different medicines out there. I think I heard they sold out Ozempic twice. The one that causes weight loss. It's for diabetes. It's 1 shot a month or a week. I have patients losing a tremendous amount of weight with that. I'm concerned because of what it does to your GI system. And so my concern and why I bring it up, remember I said medication down there is one of the things as well. Pay attention to what you're taking, why you're taking it, what your doctor says about it, what your pharmacist says about it, okay? Weight loss. What happens with weight loss is, who knows first? You. You're the first person that notices it. Or maybe your loved one. If someone hasn't seen you for a while, if you don't get on a scale, or if you don't pay attention, maybe you can miss it. But if someone sees you, they're going to notice it. What do we do with weight loss? Does it automatically mean we need a colonoscopy? No. Do I recommend it? Yes. Okay. Why? Because it's direct visualization. You can see the whole colon. Why I put it up is, it's the third most common presentation I get in my office for colon cancer. So a patient will come in, hadn't seen him for a while, we notice a weight loss, or their family makes them come in because they notice a weight loss. And what we do as we go through how your bowel habits, how your eating habits, all those things, you kind of come to the conclusion that there's been a change in all that because of the way the GI system is working. So once again, weight loss, probably fourth on the list. Okay? Taste. Did I spell that right? Taste is so important for GI. What does that mean? We don't realize what's in our mouth. I'll try to do a schematic that everybody can appreciate. This will be your jaw, and then we'll put some teeth in here, okay? We have parotid glands that sit here. We have other glands that we call them submandibular that sit here. And if you're looking at the inside of the mouth, they have secretions that occur when you chew. So when we're chewing our food, and it's supposed to be 30 times that you chew the food, all those secretions occur, so metabolism starts in your mouth. Does everybody follow me? If we don't chew 30 sometimes, and if we don't drink enough water, what happens is they really don't do anything to the food, so the food makes its way down to the stomach without any pre-metabolism, let's say. So the stomach has to work harder. Does everybody understand the concept? You have to pay attention to what you're eating. You have to pay attention to chewing and swallowing. And the reason I say pay attention, because we don't think about it. Like everybody's not thinking about their breathing right now. No one's paying attention to, am I breathing? But if you do and you stop, you'll see your chest expand, okay? We can't see into our stomachs, but we get a sense of what's happening. And if you're not chewing 30 times, or at least 20, 25, you're not using any of the glands in your mouth that are set up to pre-digest the food. If you start doing that, you're going to see a difference. I'm just bringing it up so everybody understands, okay? So what happens is, from chewing the food to swallowing the food, we have output enzymes, because that's the most common things that they secrete, and water, all right? So that's all starting in the mouth. We'll draw it from the mouth sideways. We'll go down like this is the esophagus, and then we'll draw the stomach like this. We'll put the big S for the stomach. All right, so what we have is, if you chew the food and these enzymes begin to work, as the food's making its way down the esophagus to the stomach, it's being digested. We call it a bolus. What you swallow is a bolus of food. Before it even hits your stomach, it's being digested. It gets into the stomach. When it gets to the stomach, there's a signal to the liver and the gallbladder, if you have one. And there's also a trigger to the pancreas. And what happens is the C loop, called the duodenum, is where those secretions occur. That is so important for proper digestion and good GI health. So you shouldn't rush it. You shouldn't be in such a hurry that you don't even pay attention to it. You should sit, and if you have the time, recommendations 20 minutes. I tell patients, please try at least 10. Just sit there. After you finish eating, make sure in your proper posture, feet down, your backside against the back of the seat so you're sitting straight up. Once again, you're going to notice a difference, because what are you doing? You're allowing your whole digestive system to work the best it can. And if you move around, because I had a patient, we couldn't figure out why she had reflux. Doctor, I sit for at least 10 minutes afterwards. I'm telling you, I sit. I said, okay, what's your posture? She was fine. What's the first thing she does? And once again, when the husband came in, he said, maximum 6, doc. She never sits longer than 6 minutes. What's she do? Gets the soap powder to do the dishes. That right there is reflux. And we couldn't figure it out for the longest time. You have to pay attention to the posture and what's going on. Right at the xiphoid process, which is the breastbone, that's the level where everything is. And while that's all happening, just pay attention to how do you support it the best. Relax, stay seated, don't be in a rush, and sit for 10 minutes afterwards. 20 is recommended, but at least please try 10. And what you will see is more efficiency of your body. Why is that important? Because remember, it's going to make its way from there. It ends up, after it gets down past the esophagus, oh, this goes way back. After it gets down past the esophagus, we get to 150 feet of intestine. So think about it. If you swallow it and you're in a hurry, nothing's going to happen until it gets to the intestine. What does that mean? That means that the intestine's working harder, and all the acids in the stomach didn't break up all the things that would have been broken up. So now small intestine's dealing with a lot more. So what happens? That bolus that comes through to the colon, what's in there is less digested. Please understand that. It is so important, because what's added to the foods, as we're going to talk about now, is the culprit. And so you have to pay attention. You want everything in and out of the system as fast as you can. Not diarrhea or anything like that, but you make sure you're going to see a change. If you chew the food, like I said, go at least 20, 23. I'm telling you, you won't know the food's in your mouth. And people tell me, I can't chew that many times. I said, just try it, because you won't realize, you'll swallow and won't even realize it. Please give it a try. All right, so now we're back to what happens. The patient comes in, one of those symptoms alert us, and we do a C-scope. And what do we find, and where do we find it? The most common spot is lower descending colon and sigmoid colon. I took over a practice. This is the sigmoid, and that's the lower. So I would say right in here, okay? I took over a practice that was owned by a family practitioner in the community, and he told me, he said, come on down and meet the practice. That's how he said it, meet the practice. So he told me to show up 7 o'clock on Saturday, okay? And I walked in, and he was already examining the patient. He had the patient, kept his tennis shoes on, in his underwear, walking the treadmill. Chest leads on, all the equipment right there for a stress test. He went from the stress test over to the table with his head down and his backside up, and the doctor did a sigmoidoscopy. And then he flipped him over on his back, drew his blood, checked his prostate, did an examination, and let him out in about an hour. And I was so amazed that this was happening with family practitioners in the Pittsburgh area, and this would have been in the early 80s. That was the standard. That was the standard physical given by family practitioners in this region. And then it all changed, and that's a whole other discussion. But my point is, what he used to say was, with the rigid sigmoidoscopy, they can get to 90% of those lesions. In that position, you can get the curve isn't as, I put it this way, the tissue's movable without any problems at all side effect wise. And so I observed that and I watched it and I said, well, why are we doing the colonoscopies then? You know what he said? And that was in 1982. So the reason I bring that up is we don't do the sigmoidoscopies anymore. But that was part of their physicals every year with their males and their females, With the females, they would do the they'd do the pelvics, and then after the pelvics, they'd get the same sigmoidoscopy. And that was their annual evaluation, and they picked up everything. So my whole point to it is there's prevention, you know your body, please pay attention if there's a problem. All right, so we get the patient in, we do the scope, and we find the most common adenocarcinoma. I was just telling a story yesterday. Oh, we hired a new girl. Her name is Lexi. Just hired her yesterday. I'm excited. Somebody that's going to listen to me. Everybody tells me what to do right now. Anyhow, we hired a girl. This is back about 20 years ago. And she was a secretary, but she used to work in a beauty shop as a secretary. She had no medical background. So what occurred was I called the pathologist in the morning on a patient that had a colonoscopy. And I said, please call my office to let me know the results because the patient was worried. So she answers the phone. Community Care Plus. He's like, this is Dr. So-and-so. Mr. Rudolph had Mr. Harold, that's what his last name was. Mr. Rudolph Harold, as he said Harold, he said Harold adenocarcinoma. Okay? That's all he said. And she said, thank you, and hung up. What did she interpret? She heard had no carcinoma. She didn't understand what adeno was to begin with, and she heard the H, and she said, had no carcinoma. So this poor guy didn't think he had a problem. Thank God it was early, and he was fine after it was removed. He had no problems. But my point is that adenocarcinoma is what you're going to find in the colon. Okay? If there's other things there, there's related to the musculature, and it's not something that we worry, quote unquote, about. It's the adenocarcinoma within the colon. Where it's located is also important, just again based on for treatment. So you find it. What's a stage mean? 1, 2, 3, 4. For medical purposes, we use that. For what your purpose would be is, did the colon cancer stay in the colon, or did it spread? And if it spread, where? So if it was in the colon and it spread to another part of the GI tract, that's one thing. If it's in the colon, it spreads to the bone, that's one thing. If it's in the colon and goes to the brain, that's another thing. And you can imagine stage 4 is when it's out of the colon and makes its way to the brain. So everybody understands that we get the patient in. I told you those 5. Most common is GI bleed, weight loss, the anemia, change in bowel habits. But they come into you with the information, you do the testing, you get the information from the colonoscopy. A biopsy has to be done. Once you get the biopsy, we stage it. So now we end up with the colon cancer identified, so we'll put pathology positive. And what do we need to do? Now that we've identified it's adeno, please, anybody you know in this situation, 100% of the time, you need an oncologist. What's an oncologist? The study of cancer. Okay? I had a good friend, played softball with him. If anybody's from the North Hills, the stadium at Ross, it's a park. If you're on Babcock Boulevard, it goes up to the top of the hill. It's across from, I can't remember the name of the fish place. Anyhow, it's off of McKnight Road on the top of the hill. It's called John Herb Field. Johnny Herb and I were personal friends. Long story short, we played softball every Sunday together. Myself and a kid by the name of Kevin were the only non-police. It was an all-police league. And the first game I went to, after it was over, we went back to a police officer's car, and he opened the trunk, and it was full of beer. And that was the beer he confiscated for the week. You know, and it's like, hey, Matt, have a beer. So he cracks the beer, and I take the beer, and I say, okay, guys, I'll see you later. Oh, I'll have another beer. I said, oh, man, I already had one. Oh, don't worry, if you get pulled over, just call us. But, all joking aside, Johnny was the life of the party. And his mother had colon cancer. I convinced him to go get a colonoscopy. You can get, and I'm not saying don't use a surgeon. Don't get me wrong, guys. Once again, remember how I told you the family doctor that I had did the executive physical every year on all his patients, where he did a stress test, he did a sigmoidoscopy. Well, that's the way some surgeons are. So, and that's a good thing. They were general surgeons. But this surgeon had him get a colonoscopy, found the cancer, removed the cancer, and told him he caught it early, he had nothing to worry about. And when I saw him, I played ball with him. I said, John, do you have an oncologist? No, he said he got everything. I said, please get an oncologist. He didn't get an oncologist. It was 6 years later, but it recurred. And it took his life because of how far along it was. And he was young. He was only in his early 50s when he passed. You know, I play softball now with his son, who's a cop too. You know, I kept it in the family. But my point to it is, an oncologist knows cancer. I want to try to give you that expertise. Like a stonemason knows stone. You guys ever seen those little Italian stonemasons? Like they'll pick up a piece, and with this little chisel, they'll look at it, they'll look at their space, hit it, and it's done. And that's how an oncologist is. An oncologist knows the cancer. They know what the cancer is going to do. They know how it's going to spread. They know how it's going to get from point A to point B. They know what tests to use to make sure it's not growing. And they have now, you know, a whole army of things that they can use. Everybody calls it a toolbox. And nowadays the oncologists have navigators. What's in the toolbox? Everything. What does that mean? Surgery, of course. Radiation is there. They have disease modifiers that are out there now. So if you can find the enzyme that changes the polyp to mutate to a cancer, they can treat that. They also have the autoimmune. That's how the body works. They block the immune system. So there's many, many, many treatments, but you gotta catch it early. It's a must, guys. That's the whole purpose of today, is to make sure everybody understands. Here in Pittsburgh especially, any hospital in the city of Pittsburgh is excellent to find and treat the colon cancer with the surgeons that they have affiliated with their hospital. But you have to have an oncologist. Please don't, I can't, not just because of John, I've had other patients where I did not pay, well, I shouldn't say I didn't pay attention. I definitely paid attention because the surgeon would be seeing them back. And then even do a colonoscopy. But they didn't follow like an oncologist does. You know, my patients to see oncologists, like they tell me, he wants me to get this test, this test. And I said, get it. That's how he's keeping you alive. He's staying ahead of all this. Whatever he or she's telling you to do it. Because they read constantly, and again, they know the tumor. They know how the tumor grows. They know how the cells divide. They're on this stuff. Please pay attention. Anybody you know, anybody in your family, anybody, if you hear the word cancer, ask them who their oncologist is. Because anybody with cancer is not going to be worried about talking about their cancer anymore. Years ago it was a stigma. Now people don't mind. And you want to know. You know, you want to know they have an oncologist. And if they tell you, oh, my doctor said don't worry about it, say, I told you to get it done. Just see him one time. That's all you have to do, is make sure you get in to see the oncologist one time. And they'll make sure they tell you everything that's going on. And I guarantee before you walk out, you're going to be happy with the person, and you're going to come back next year if that's what they tell you to do. Because that's how they stay on top of it. Okay, so what occurs now is based on where it has spread and where it hasn't spread, one of those treatment plans are what we deal with. So surgery, I have to put 100% of the time because you got to remove it. Well, let me take that back. God forbid it's far along. We've had it where the tumor pushed inside of the colon and it was obstructing and the patient was debilitated, and family and the team felt like not putting him through the surgery because we didn't think that the outcome would change anything. So what we did was we brought out a colostomy, so that he had no problem with everything down below. And he lived 6 years, but the point is that what happens is decisions are made, but surgery is tops on the list. You need a surgeon. And that's why I tell patients, I used to have a card. I got to get back to that. When you give your insurance card to your doctors, list your surgeon. And if you don't have a surgeon, talk to your doctor or friends, whoever, get the surgeon's name on there. Why? God forbid you go to the hospital, you go to the emergency room, and they ask you who's your surgeon, and you don't know, they put you in the pile called house service. And what that means is the residents take care of you. Everybody needs to learn. I have 2 boys that are learning. But that's not what you want in any kind of a surgical situation. So you pick the name. Find out a general surgeon, find out an orthopedic surgeon, find a cardiovascular surgeon. Just get their names. And patients will say, well, I've never talked to them. Trust me. You call in and say, like if the nurse calls and says, Mrs. Smith's in the emergency room and she wants Dr. So-and-so, she has such and such, no questions asked, they come and see you. Maybe when they're seeing you, they'll say, hey, who referred you? Tell them I referred you. Because you definitely want to have a plan. And I don't want anybody to need an oncologist. I don't want anybody to need a surgeon, but you want that. And again, it depends on the system you're in. If you're in a certain healthcare system, if you have to go, say, with AGH, find out who the oncologists at AGH are. I know Dr. Long down at AGH. If you have to go over to Pasadena, that's a UPM system, I know Dr. Rajasena over there. If you have to go over to Heritage Valley at all, Venus Hadid. I laugh because Venus looks the same she did. She was my resident. She was a year under me. And she still looks like she's 20 years old. But she's with the Heritage Valley system. My whole point is these are all experts. They all know what they're doing. They know how the cancer acts. So please, have to have an oncologist and tell anybody you know that's ever had a cancer. So you have to have the surgery. After the surgery, the tissue guides the treatment. What does that mean? If you have an aggressive tumor, they probably hit you with a anti-immune type of drug. And they're good, they work. And what it does is your body's immune system is fighting the cancer, and in the process, you're getting a lot of cellular damage around it. So they target these cells that are dividing, and they kind of back off your little army, and people get good responses. But once again, that requires seeing the oncologist, and they do PET scans and CAT scans. I mean, you have to have this stuff done. I have so many patients that just complain. Like, oh, I have to get another scan in 6 months. And I say to them, like, look, the cancer's not there anymore. He's doing it every 6 months to make sure it stays away. And generally what they'll do is probably for 2 years, go every 6 months or even 4 months, and if nothing's there, then they'll cut back to once a year. But again, the oncologists know this based on the protocols. Ultimately, once the treatment is established, most everybody will get what's called a PET scan. What's a PET scan? It's called positron emission tomography. Basically, they squirt sugar in your vein, and they have a big camera, this nuclear medicine, and it comes and sits over your body, and that sugar that's traveling through your system, if there's a tumor, cancers grow faster than regular tissue. So if there's a tumor, there'll be an uptake into that tumor area. Now, uptake can occur from inflammation, uptake can occur based on the blood flow, It's called SUV, standard uptake value. And there's a number based on the part of the body that it is. I have a good friend, Dr. Wapinski. Actually, we're having breakfast tomorrow. He's a nuclear physicist, and he was in UCLA and was part of the team that designed the PET scan. And I remember him talking about they can find the smallest of cancers nowadays. And that's what led to people surviving longer and ultimately better treatment protocols, because you can follow it up. So again, somewhere in there, you find out the standard uptake value for baseline. And then you treat, and now they do CT PET scans together. Once you're done with the treatment, they'll do a CT PET scan, making sure that that standard uptake value went down and make sure the tumor shrunk. And then they follow it up again based upon what they think your treatment response was. They may want you in every 3 months, every 4 months to get evaluated and a scan, or if it works, they kick you out for a year. And then they always track the 5-year survival rate. And at the end of the 5-year survival rate, as long as you're above the statistics, they'll kick you out for a while and let your PCP let them know if there's any problem. So I can't overemphasize identifying the cancer early. Pay attention to your constitution. If there's a change in it, tell your doctor. Get the colonoscopy. If you haven't had one, you need one. Do the Cologuard every year. It's so important and it's so simple. And then ultimately, pay attention to what you're eating and drinking. People don't read labels, guys. The genetically modified foods that we eat, if you're not reading it, it's ridiculous. Have you guys seen the commercial about making meat out of whatever the hell they're talking about, vegetables or something? That is genetically modified. I would not recommend it to anybody. You know, but the point is that that's where we've all moved to. You know, like these like the corn, they're telling me most of the corn's genetically modified now. Those are the things that can cause the mutations. So please pay attention to what you guys don't have anything to worry here. I'm talking about tell your friends and family. Here they pay attention to everything. But the point still is, read labels of drinks that you're getting. If it has fructose corn syrup, that's sugar. And if you're drinking those and not paying attention, that's a lot of sugar. It's 50 times stronger than sugar. So please, guys, pay attention to it. Okay? Last thing I leave you with is the med beds. I have a friend in, let's see, next Wednesday, the 24th. He's going in. First person that I'm personally sending. So we'll probably do that talk in about 3 or 4 months, because the technology, the guy I told you about that's the nuclear physicist, he went to the presentation with me and he says it's for real. So the med bed treatments are coming. You'll hear about it. So you heard from me. Any questions, guys? Yes?
A number of years ago, I've been told that once you turn 80, they don't recommend colonoscopies anymore. But the last time I was into my PCP, she said it's down to 75.
Well, I think that that's all based on your health. What happens is that what they have found is people over the age of 70, the colon isn't as forgiving, if you will, because it's a scope and pressure. What they do as they're going in is there's a pressure that opens up the colon and they just follow it around. And the concern is that they had more of an incidence in over 70s than under 70s, and that's where that all came from. But personally, if you have problems, I still talk to the doctor and still recommend, because you're directly visualizing it instead of a barium enema or instead of a CAT scan or even an MRI. So it still gives you a definitive look at the colon and the mucosa. So I think it's individualized based upon the patient. I mean, if I have patients, no family history at all, they've had 2 or 3 colonoscopies that have been normal, and they're pretty healthy people, I wouldn't recommend it. But I wouldn't hesitate. Age doesn't necessarily factor in terms of my thought process. I'm still independent, so no one tells me how to do it. And I still had a patient he was told not to get his prostate checked, PSA or anything, after the age of 75. You know, we did his radical prostatectomy at the age of 84, and he lived to 96. You know, so I mean, it's the individual. You know, he was like a real hefty, healthy guy, but he was definitely paying attention to what he was doing. So I might not disagree in certain people, but yourself, just looking at you, you look healthy enough to get it. If there was any concern, then I wouldn't hesitate. You just have to get the right doc too. You know, I would talk to your PCP, and someone will do it.
I just wanted, I couldn't hear what you said. Did you say that somebody else is gonna be talking here? I couldn't hear what you said the last.
Oh, no. What I said was the med beds, they're called. It's a new technology that's out in healthcare. And it has to do with wavelengths that have an impact on your cells that produce energy. And it gives you more energy, and it lowers the inflammation in your body. And I haven't had a patient yet. My first patient is going next Wednesday. And I'll be talking about it here probably in about 3 or 4 months. I want to get the data. Once I get the data, but I'll pass them.
You are going to come back.
Talk about it. Yes.
You were very good. I have to leave now, but thank you very much.
Sure. Thanks for coming.
Hear you except that very last, and I want to go to the next one.
I'll yell at this. I'll make sure I yell. But do me a favor, guys. I want everybody to pass along that Dr. Coppola had a dream. He had a dream that he was in the assembly room at Masonic Village, and when he finished, he was so delighted to see the 3 trays of cookies that used to be over there with coffee, decaf, regular. Pass that along. I had a dream that I came back to see that.
It's funny that you say that because we were just talking about that at lunchtime.
Remember that though?
Yeah.
Seriously. And I would admit, I'm taking 4, guys. 2 when I walk in and 2 when I'm leaving. Maybe that's why they shut it down. I took too many. But there would be 3 trays of them, right? 3 trays over there, decaf, regular. It was wild. It was nice. So tell them I had a dream.